Hi, I'm Zavin. I'm going to give a 10,000-foot overview of atrial fibrillation and offer a couple of quick pearls. So atrial fibrillation occurs when abnormal impulses begin in the atria, several waveforms, electrical waveforms that make the atria simply quiver and bombard the AV node with hundreds and hundreds of impulses per minute, some X percentage of which are transmitted to the ventricle to result in an irregularly irregular and often abnormally fast ventricular rhythm. So I'm going to talk about the causes of atrial fibrillation pathophysiologically, some treatments to focus on, and a couple of pearls. So the way I want you to think of the triggers of atrial fibrillation are in two broad categories. One is increased atrial pressure or stretch. So if you think about a lot of those causes, things like hypertensive heart disease, or cardiomyopathy, or heart failure, or pulmonary embolism, a lot of those mechanisms have the final common pathway of causing increased pressure or stretch or dilation of the atria, especially the left atrium. The other broad category are direct atrial irritants. So a couple of examples of those are norepinephrine, ethanol, or thyroid hormone. These stand for themselves as pretty unique and narrow entities. However, you can also imagine that increased norepinephrine states are also a final common pathway of a broad list of other causes: sepsis, myocardial infarction, neurologic catastrophes, stress, you name it, adrenergic drugs, etc. So when somebody comes in with atrial fibrillation, don't assume that it is just that's a final diagnosis. Always ask the question of, okay, but what triggered it, and consider all of the causes in this diagnostic schema. Okay, if somebody does come in atrial fibrillation, what do you have to worry about? The two problems that arise are too fast of a ventricular response, which in and of itself can cause symptoms, trivial symptoms like a mild annoyance or a sense of palpitation, all the way to much more severe symptoms of chest pain, demand ischemia, etc. So oftentimes one of our big goals in treating AFib is rate control. Good studies have shown us that trying to get people out of atrial fibrillation oftentimes doesn't work as well, and oftentimes, especially in the acute setting, the goal is simply to prevent the ventricles from responding to that bombardment at such a high rate. So if someone's blood pressure is normal, we can reach for beta blockers or non-dihydropyridine calcium channel blockers. And if the blood pressure is low, our options are amiodarone or digoxin. The second goal, and this is more of a long-term consideration, is prevention of thromboembolism. So these quivering atria, especially the left atrial appendix, is going to have relative stasis of blood and a propensity to form clots, which can then embolize up into the brain, into your legs, into your mesentery, and cause big problems. So anticoagulation benefits many patients with atrial fibrillation, depending on their degree of risk of thromboembolism as determined by many of the excellent risk prediction scores, specifically these days the CHADS-VASc score. Okay, so that's the broad considerations of what caused this and what do we do about it, at least in the short term. And a couple of pearls that I want to leave you with are that, one, in some cases, atrial fibrillation is very poorly tolerated, not only in terms of these things that I already mentioned, but specifically in terms of the hemodynamics. So when you lose your atrial kick, if it's a normal heart, a younger person, the atrial kick accounts for about 15–25% of the preload. And when that goes away, not a big deal. However, if you have long-standing hypertension or aortic stenosis and you have left ventricular hypertrophy and thus stiffness of your ventricle and diastolic dysfunction, oftentimes the preload is actually much more dependent on the atrial kick. And when the person goes into atrial fibrillation and loses that contraction, their preload drops substantially enough for their blood pressure to suddenly go from 150 to 70. And it's in those cases where you often have to achieve rhythm control in a more urgent basis, either chemically or with cardioversion. So, stiff LV, poorly tolerated. The second pearl pertains to patients who are chronically in atrial fibrillation. So a lot of times people will be in persistent or very frequently paroxysmal AFib, where they come into the hospital and they're symptomatic now because they have rapid ventricular response, and we're no longer going through the framework of, okay, why did this person go into atrial fibrillation? Because the diagnosis is long established and we already have known reasons for the AFib. The person has known hypertensive heart disease or heart failure or whatever. In those cases, however, it's still worth asking the question, okay, we know why AFib, but why RVR? Why is this patient suddenly tachycardic within the same rhythm that they've been in? And the differential for that question is the same differential as that of sinus tachycardia. The same norepinephrine, the same hyperadrenergic state that drives all of the causes of sinus tachycardia is now causing enhanced transmission of the AV node, and you should thus consider hypovolemia, GI bleed, sepsis, whatever you would normally think about for sinus tachycardia as the cause of exacerbation of normal rate control in someone with established AFib. So, if someone's newly in rapid ventricular response, it's the same differential as for sinus tachycardia. Okay, so in summary, AFib, extremely common arrhythmia. Think about these categories of causes of atrial fibrillation. These most common goals of treatment in the short term, as well as considerations of why AFib may be poorly tolerated hemodynamically in some patients, and what to think about when someone has new tachycardia even though they've been in AFib for a long time.